Thank you so much, Dr. Goulet. We are going to transition to our third block of abstract presentations, and it looks like perfect. So Dr. Isabel Siqueiros, who's joining us from WSU, is going to be sharing with us a very unusual cause of altered mental status. If you want to go ahead and pull up your slides. Uh, I also just want to let all the judges know after this third set, we will be put into a breakout room where we will be able to review. All right, slides look great.
Okay. Hello, everyone. My name is Isabel Siqueiros. I'm a second-year internal medicine resident with Washington State University at Providence in Everett. And today I'll be presenting a clinical vignette about a case that we encountered early this year that we titled Hormonal Hyperventilation, an Uncommon Cause of Confusion in ESRD Women. So, altered mental status is a common cause of hospitalization in ESRD patients. Most commonly, we think about uremia, infection, or electrolyte disturbances as an etiology. However, one factor that is frequently overlooked is impaired drug clearance. In particularly with hormonal therapy, especially in high doses, this can behave very differently in women with ESRD disease. This is because of altered pharmacokinetics that they suffer. I'm gonna start the case presentation. This is a 44-year-old female Spanish speaking that presented with altered mental status and discomfort at her catheter site. On arrival, respiratory rate was slightly elevated to 20, but the rest of her vital signs were stable. Review of systems was essentially negative. On exam, on her catheter side, we could observe a mild non-purulent discharge, but other than that, her abdomen exam was without any signs of infection. The remainder of her physical exam was unremarkable. Some recent pertinent events that she had: 1 week before admission, she had a local catheter site infection. 3 days before admission, she had a vaginal bleeding, for the which she received 3 units of blood transfusion. She also received a high-dose hormonal therapy taper to control the bleeding, and she missed peritoneal dialysis for 3 days. Further workup was only remarkable for BUN at her normal range. Her creatinine and GFR were at her expected range. Otherwise, basic panel and CBC were unremarkable. Although her catheter fluid did grew some bacteria on it, the cell count was not consistent with an active infection. The blood cultures were with no growth, and the imaging that we did for her was without acute abnormalities, including a CT head scan and an abdominal ultrasound. In the ED, they draw a BBG that it was quite interesting. The pH was very high and the PCO2 was very low. And this was pointing to a primary respiratory alkalosis. Her bicarb was also high, meaning that she was not compensating as expected in healthy persons. It is at this point we have ruled out multiple differential diagnoses and possible etiologies for her presentation. And that's when we started thinking about estrogen and progesterone. It is well known that estrogen and progesterone can increase our respiratory drive, particularly by stimulating the hypothalamus and brainstem respiratory centers. This can cause hyperventilation and respiratory alkalosis, driving to a neurocognitive syndrome presentation. When we discovered this, we restarted her peritoneal dialysis and we immediately discontinued her oral contraceptive medication. On day 2, her mental status was normalized back at her baseline. Um, a couple of hours later, the cultures that we got from her catheter did grew Serratia, Corynebacterium, and we gave her a couple of antibiotics. But this was basically the only interventions that we did for her. It is well known that estrogen metabolism in ESRD patients is impaired. There's an interesting study in the early 90s that did compare 11 women with peritoneal dialysis ESRD versus 9 healthy controls. And if we observe this graphic, in the y-axis, it shows estradiol levels measured in the serum, and in the x-axis, we can see the time points at which the samples were collected. For the estradiol imaging, there was a significant increased area under the curve in patients with ESRD. This was compared to the healthy controls. For progesterone, this was not statistically significant. The mechanisms that the authors explain is that estrogen is not removed by dialysis. Since that study, multiple studies were done, basically resulting with very similar conclusions, meaning that ESRD women have reduced estrogen clearance and much higher systemic concentrations than healthy people. So the takeaway points of my presentation is when we combine all contraceptives, especially ethinylestradiol, this can be poorly clear in ESRD patients. This can point to a risk of accumulation and toxicity and change in mental status. Progestin-only regimens are actually a safer option in ESRD population. So always assess hormone therapy in patients with unexplained metabolic or neurological changes in ESRD patients. Thank you very much, everyone, and I will be happy to answer any questions you could have.
Great. Thank you so much. That was a very interesting review of physiology that probably harkens back for most of us to medical school. We have a couple questions, and the first one I think you strongly allude to, but it sounds like for your patients who are end-stage renal disease on dialysis, so then you would recommend using progesterone-based rather than combined estrogen progesterone.
Correct, correct. Actually, for this patient, it was quite interesting that when we discharged her, we restarted her hormonal therapy but at a lower dose, and then she followed up with her OBGYN, who switched the medication to only progesterone, 5 milligrams. Since then, she hasn't had any more acute situations.
That's great. And I really appreciate the follow-up. Uh, and then the next question is building on that physiology. So can you kind of walk us through like the connection between estrogen and the respiratory alkalosis? So like how is it that the estrogen is doing that as opposed to the progesterone?
Well, they actually both can stimulate our respiratory centers. Progesterone a little bit more than estrogen, but progesterone gets dialyzed, so it gets clear. But what estrogen does too, it also stimulates the centers and also increase the receptors of the brainstem for progesterone to act too. So basically, both they can do it.
But the progesterone gets cleared by the dialysis at a higher rate than estrogen. Okay. Thank you for walking us through that. This was a wonderful case and really great discussion regarding the physiology. So thank you so much.